Great, thank you. These are secondary outcomes from our randomized trial that compared peer-assisted telemedicine for hepatitis C treatment versus peer-assisted usual care or refer to local providers for hep C treatment in rural people who use drugs in Oregon, and we're focusing specifically on unstably housed folks. We had NIH funding, including the ROI, but no other conflicts. So we know that unstable housing is associated with higher hep C prevalence, but lower hep C treatment. And so we want to see the effects here. In our study, we found that among our rural population, peer-assisted telemedicine, our intervention, was very effective with a relative risk for a cure of about 4. And we thought a few of the elements of our intervention would be really relevant to homeless folks, like you're paired up with a peer for the whole time, and the peers got you a lot of access to things, including even housing sometimes. Peers also help folks access testing and really low barrier settings, low barrier access to telemedicine provider visits, and navigating very complicated systems like specialty pharmacies, which was especially relevant for people who didn't have an address. So our hypothesis was that housing status would moderate the effect of telehep C. We looked at a main outcome of hepatitis C viral clearance at 12 weeks, SVR12. The main exposure was the group that one was randomized to. And our effect modifier of interest was unstable housing, which was defined as self-reported homelessness within the past 6 months at baseline, with homelessness broadly defined. Here's our results. We recruited 203 people. 70% of them were houseless. And overall, we did see that unstable housing was associated with lower hep C viral clearance, 34% versus 50% among housed participants. However, when we looked at things stratified by housing status, we saw something interesting. So here in the top row, you see that there is, in fact, an interaction in the model between randomization and housing status. In the second row, you can see what happened with telehep C for stably housed folks, and you can see telehep C is effective for stably housed folks with a relative risk of cure of about 2. But in unstably housed folks, you see that telehep C is super effective with a relative risk of cure of 6.5. There's some limitations. We're underpowered to do a effect modification analysis, but the direction of our findings are consistent with the literature, so I think it's a true result. And then some of the elements of the intervention we couldn't fully pull apart in the collected data, and so we can't comment on the specific features of this sort of bundle that contributed to the success for houseless folks. However, I can say that peer-assisted telemedicine for hepatitis C is 3 times more effective in unstably housed folks compared to stably housed folks. And it's a big bundle of interventions. That's key features are flexibility, low barrier to access, and peer leadership. Thanks to our participants, peers, collaborators, and funders, and thanks for your questions.
Thank you. Questions from the floor or through the app? Yes, Brian?
How do you do telehealth with someone who's houseless?
Yeah, that's a key feature. So our peers have their own devices that they go out into the community and provide the telecommunications. We would not be able to do it without that. Most of our participants also camp out in the woods in rural Oregon, really dispersed area, and very few people have access to the internet or phones.
Question in the front there.
I think mine is a comment that looks at just the pattern that I'm seeing relative to cure rates. It seems that adherence is a big issue, especially those who are not housed. And with our actual study, the question was, do we see a better outcome if we dot the patient, meaning directly observed treatment daily by a clinician, in comparison to giving them a 7-day course to do it on their own, homeless as they are? And generally, what we see is that, the directly observed treatment would be the one that works best. And I think it does then come to the answer of how we can improve cure rates, and with the homeless community that becomes quite a challenge.
So we don't do DOT. The HERO study showed that there wasn't a benefit for DOT versus peer-assisted or care navigation assisted. And so we don't do DOT. I don't think we need it, but I think that's all. Sorry.
Okay. We'll move on to the, thank you very much.